you might go back to page 5 if you want the definition. Page 5, you can page 5 if you need page 6.
So it involves financial incentives.
The broad set of payment strategies. I look at as it applies to several different areas. I know John Stephen addressed it with the pharmacy side of it. So as far as like trying to purchase services, purchase medications and services at a cheaper price, but then it also has to do with the patient-centered medical homes and essentially trying to provide services through that incentive, trying to provide better service. So with the patient-centered medical homes, if you know, as a group of providers can save $10,000, will cost share $5,000 back. So this is just directing the department to look for those value-based strategies that might be effective to implement in Arkansas.
Okay, we got Sarah Elliott, you're recognized for a question.
Thank you, Mr. Chair. I got to agree on page 9, and I have 2 questions. Beginning on line 18, where it reads new healthcare programs and strategies, including without limitation. And I know that a lot of times we use that language without limitations in our bill, but should I read that to mean that if we wanted to add something else at some point after D, we discovered something else we could do? Does this give authorization to add something else? Or is that just such generic language that's just the way the law is?
Mr. John Stephen did write this part for us. The way I interpret that, and if my interpretation is not right, we can change it without limitations, so we can add to it if we need to, but these are a couple of the things that we definitely wanted to spell out that we start with. So I read it as in, you can add to it.
But would we be adding to it under the direction of whom? Who would be doing that?
Department of Human Services.
Okay, and then do you know if that would be something that would bring by us, or?
It should go through rules and regs, is what it would go through.
Okay.
Any type of policy change like that would go through rules and regs.
Okay. And then the more specific question, I don't know what quality reporting for Medicaid providers means, if it has something that is, a part of the structure of the medical profession or CMS.
Okay. I can give you an example, like with the patient-centered medical homes, what they have a set of the criteria, the quality outcomes, the metrics. And so what we're wanting to accomplish with this is to implement this for the behavioral health and the DD populations as well, to show those metrics. And then also within the administrative services organization, they have very broad analytics capability to where they can take all the claims data, all the diagnosis data, and they can show trends. And so what we're wanting with this quality reporting is to be able to essentially shift healthcare by looking at these trends and analytics. So,
Well, you might explain that physicians now, PCPs get a panel of all the charges for those particular patients, so it allows them to sort of track what services those people have had, and if they feel like there's overutilization, and the primary care physician can question those services because he is ultimately responsible for his patients. Lisa, you might talk a little bit more about that.
Yeah, but this is something that we can currently do within Medicaid. I mean, we have for different years. I mean, we have for many years, so in different various ways. I mean, we've been able to share information with the people that are providing Medicaid services that we partner with. And so, we have the ability to be able to draw more information and share more data to show, how can we achieve quality within the services that we're providing, and are we able to achieve, the same results at a lesser cost for these patients, and try to really provide a better outcome for them. And so that's a give and a take, obviously, that you've got to make sure that you don't jeopardize that care. But I think it's important that you have the data to share it. These are quality reports, and we're saying we need to share that. We need to expand that into these other populations where that does not exist currently.
Okay, thank you, Mr. Chair.
Could I add, as she said, 80% of Medicaid patients are already in a patient-centered medical home, and there are other quality measures that are required of that. The first year of the patient-centered medical home, it saved $34 million. And they're required to have 24/7 coverage and same-day appointments and a lot of quality measures that are a part of that. And we just want to bring behavioral health and developmental disabilities into that model of quality care. I think it's also important for us to understand who these populations are. When you say developmental disabilities, behavioral health, that's kind of meaningless, but developmental disabilities, we're talking about kids with Downs and cystic fibrosis and spina bifida and really serious developmental problems. And the behavioral health aspect, you're talking about kids with autism and all kind of developmental delays. So it is a very vulnerable population, and while we want to save money, we don't want to do that at the expense of patients.
So those quality measures, though, to be, so that can be clear, are already determined. And for,
Not for behavioral health and DD, but they are, it is what we want to extend the behavioral health and DD population.
and you're just checking to
these.
see, keeping track of how you make those marks.
Right.
Senator Dismayne, you recognize for a question.